Good morning. Today we are going to learn about how to prepare for the possible emergency situations in hair transplant. Hair transplant basically is a safe outpatient day surgery. It involves only skin, subcutaneous tissue and done under local anesthesia. Emergencies are uncommon but can appear. Many of the emergencies are preventable. Clinic doctors and support staff must be prepared to manage the emergencies. Mortalities are rare, but we all know about Chennai and Mumbai case. Potential medical conditions which may convert into life-threatening emergencies during hair transplant are medications, lidocaine toxicity, drug interactions, over-sedation, anaphylactic shock, hypotension, Vasovagal syndrome, angina, cardiac arrest, dyspnea, asthma, seizures, stroke, bleeding disorders, and accidental injury or fall. So there is a long list. And to avoid any unwanted event, thorough pre-op preparation must be done. We must take history in detail of all existing conditions such as diabetes, hypertension, bleeding disorders, history of heart or cardiovascular disease, HIV, hepatitis, seizures. They all can increase risk with the surgery. If patient is taking any medication, inquire in detail to avoid any drug interactions during surgery. History of allergy, past surgical history, especially any reaction with local anesthesia. Pre-op investigations, and it is always safe to obtain a medical clearance from the primary treating physician before surgery. It is important to have IV assays in all patients. Xylocaine sensitivity test must be done. It is safe to keep anesthetist in case of elderly patients or patient with comorbidities. We must be able to recognize signs and symptoms of the emergency and be ready to manage. Most important and common emergency during surgery is vasovagal syndrome. It is precipitated due to pain, sight of blood, fear, anxiety, etc. and can be very well prevented by giving preoperative sedation, friendly environment and keep talking to the patient. So any type of stress, mental, visual, visceral or orthostatic, it leads to the reflex stimulation of ANS leading to bradycardia and hypotension, resulting in decreased blood flow to the brain and fainting. Symptoms are dizziness, blurred vision, feeling warm, sweating, nauseating, and skin feels cold and clammy, and ultimately patient may faint. Management: as soon as signs and symptoms are noted, terminate the procedure, place patient in supine position with legs slightly raised, monitor vital signs. If bradycardia persists, then give injection atropine 0.5 mg IV, IM or subcutaneous. Some patients may need IV fluid to correct hypotension. If there is no response, then start with BLS. Second is anaphylaxis. Again, it is a serious condition. Symptoms can appear within minutes up to 2 hours after exposure to the allergen. Steroid and Avil, if given during surgery, they may mask the primary anaphylactic reaction and may invite fatal emergencies if biphasic reaction occur. Symptoms are swelling of the lips, tongue, throat, weak rapid pulse, severe stomach pain, dizziness, difficulty in breathing, and ultimately cardiovascular collapse may occur. Diagnosis: anaphylaxis is highly likely when there is acute onset of illness with involvement of skin, mucosal tissue or both, and at least one of the following: respiratory compromise or reduced blood pressure. Management: remove exposure to the trigger, assess circulation, airway, breathing, promptly and simultaneously call for help and inject epinephrine intramuscularly on the mid-anterolateral aspect of the thigh, 0.01 mg per kilogram of 1 in 1000 solution to a maximum of 0.5 mg. When indicated, at any time during the episode, give high flow supplemental oxygen, give IV fluids and prepare to initiate CPR. For the treatment of bronchospasm not responsive to epinephrine, give inhaled bronchodilator. If reactions are sustained, the patient must be transferred to the hospital by ambulance as quickly as possible. So if we see any sign and symptom of allergy which gets controlled by itself or by treatment, such patient should be kept under observation minimum for 8 to 48 hours, as anaphylaxis may be biphasic, appearing to resolve only to return. So on discharge, give EpiPen, which is an auto-injector for epinephrine, corticosteroids and histamine. Third is over-sedation with injectable sedatives. So symptoms are difficulty to arouse, slowed respiration, slurred speech, respiratory arrest and cardiopulmonary arrest. It is not necessary to use injectable sedatives for the hair transplant patient. Oral sedation and local anesthesia are adequate. However, if injectables are used, they must be used at minimal dosage. And cardiac and pulse oximetry monitoring should be done. Resuscitation equipment should be easily assessed and antidote must be ready. So for opioid derivative, antidote is naloxone. Dose is 0.4 to 1 milligram IV. For benzodiazepines, it is flumazanine. Dose is 0.2 milligram and repeated up to 1 milligram. Very important is overdose toxicity from local anesthetic. It may be due to accidental rapid IV injections, rapid absorption, failure to monitor dose, and a perception that lidocaine is relatively safe. Increased susceptibility in patients with significant comorbidities and drug interactions. Dilantin and beta blocker, they increase the plasma level of lidocaine. Prevention is avoid bolus injection without aspiration. And epinephrine in concentration of 5 microgram per ml, that is 1 in 200,000, along with local anesthetic, will significantly reduce the peak blood level of lidocaine regardless of the site of administration. In hair restoration surgery, local anesthesia is given in stages over a few hours, not all at once. So beware of total safe dose and of potential combined toxicity. Maintain an anesthesia log for every surgery. The log records the agent doses, time of administration and keeps a running total of each agent. Symptoms depend on the severity of the dose. Slurred speech, paresthesia, numbness, drowsiness, restlessness, arrhythmia, confusion, tremors, convulsions, and ultimately respiratory and cardiac arrest may occur. Treatment: stop infiltration of anesthetic agent, start IV fluids and IV lipids, especially if seizures, IV sedatives like diazepam and mizolam. In advanced stages, activate EMS and start with BLS. Hypertension with bradycardia, it may be due to drug interaction of epinephrine with non-selective beta blocker and may lead to hypertensive crisis. It is due to unopposed action of alpha receptors on vascular smooth muscles, leading to peripheral vasoconstriction. Symptoms are headache, restlessness, hypertension with bradycardia. Treat it as emergency, stop the surgery, stop local anesthesia and give sublingual nifedipine. Hypertension may occur with tachycardia. Symptoms are same except tachycardia is there, palpitation is there. So treatment is stop adrenaline, give sedation, sublingual nifedipine and if not controlled, shift to the hospital. If there is overdose of hypoglycemic agent, quinine or excess alcohol, there may be hypoglycemia and the symptoms are irregular or fast heartbeat, fatigue, pale skin, anxiety, sweating, hunger, irritability, confusion may ultimately lead to convulsions and loss of consciousness. So treatment is give oral glucose and if needed IV glucose. Hypovolemia, the most common cause is pre-operative poor hydration and insufficient fluid intake during surgery. There may be uncontrolled bleeding, especially in FUT, adrenaline tachyphylaxis, continuous oozing without surgeon's attention. Signs and symptoms are sweating, cold clammy skin, hypotension. So treatment is head low position, IV fluids and control of bleeding. Seizures cause may be because of hypoglycemia, anesthetic toxicity and patient with history of convulsions. Symptoms, convulsions along with altered consciousness. Treatment is maintain respiratory airways, prevent injury to the patient, diazepam, treat the cause and shift to the hospital. Now there may occur cardiovascular event, angina, myocardial infarction, cardiac arrhythmias and ultimately cardiac arrest. So upon presentation of such complaints, suspend the procedure, assess vital signs, establish IV assays, administer 1 tablet of 325 mg of aspirin and 1 tablet of nitroglycerin sublingual. Activate emergency response system and start CPR. Arrange transfer to hospital for evaluation, treat rhythm disturbances. In cases of cerebrovascular event, stroke, which is very unlikely to occur, symptoms may vary but include weakness, numbness, difficulty understanding others, slurred speech, double vision. Treatment is again suspend the procedure, have the patient chew 325 mg of aspirin, administer oxygen, activate emergency response system and do not try to rapidly lower blood pressure if elevated. If blood pressure is low, give IV fluids and transfer to the hospital. If procedure is incomplete, preserve tissue in advanced holding solution like hypothermosol with ATP at 4 degrees centigrade for possible completion once patient is stabilized. Now whatever may be the cause, most immediate concern in an unresponsive patient is to prevent brain anoxia, either due to lack of respiration or circulation. So training in BLS is must. Paste a chart with BLS protocol in operating room. Ensure the availability of all emergency medicines. Equipments must be ready. And for activating EMS and transport facility, contact number should be easily available to OT and reception staff. Recommended training for staff in hair restoration surgery. Doctor, minimum basic life support training, preferably advanced cardiac life support. OT staff shall have done BLS training or experience of working in operating room. Training and rehearsing the OT staff in emergency protocol is very important. They should know all medicine equipments and their location. So what is BLS? BLS includes psychomotor skill for performing high quality CPR using AED and relieving and obstructing airway for patient of all ages. So it helps you to recognize cardiac arrest and respiratory arrest, activate the EMS early and respond quickly and confidently. ACLS include all advanced interventions including IV drug delivery and advanced airways. So if hair transplant doctor is not used to ACLS skill, it is better to perform simply BLS and shift the patient to the nearby hospital at the earliest. For respiratory arrest, give assisted breathing once every 5 seconds, that is 10 to 12 times per minute. For cardiac arrest, chain of survival is early recognition, early CPR, early defibrillation and post-resuscitative care. And we have to shift from ABC to CAB. According to American Heart Association, start with chest compression and immediately activate EMS if you are alone. So if you are alone, activate EMS, return to the victim, CPR followed by defibrillation. If two rescuers are there, begin CPR, activate EMS and then defibrillation. Emergency drugs should be handy, all cardiac and antiarrhythmic agents and miscellaneous drugs. Emergency crash cart, basic equipments like stethoscope, multipara, glucometer, digital thermometer, all must be there along with the resuscitative equipments. Defibrillator, laryngoscope, endotracheal tubes, xylocaine spray, airways, ambubake, oxygen cylinder. And transfer arrangement with local hospital should be there. So in the case of rare event, unexpected serious development during or immediately after a hair transplant, an arrangement should exist. Ideally, surgeon performing office-based hair transplant surgery must have admitting privileges at nearby hospital, and ambulance services must be available. Thank you.